Welcome to another Ultrasound of the Week. I am Dr. Michael Schick. Now this week we have a very special case for you. Now we are going to do a multi-organ ultrasound for the first time ever on these cases, but don't get scared. Let's see the case first and put the puzzle together. So typical day in the emergency department, and you have an acutely short of breath person coming in. Turns out it is a 62-year-old female, and she presents with her husband. They're both Punjabi speaking, and you don't have anyone to immediately translate for you. The husband is able to tell you that they were driving to Walmart and she has trouble breathing. You ask about medical problems, and the husband denies anything, as well as the patient denies any medical problems. When you go through your common list of organ systems, he seems to endorse that she may have a heart issue. So you ask for a translator and also the translation phone, and someone goes to grab it, and you look at the patient in front of you, and what you see is an acutely dyspneic patient. She's sitting up in bed, she's short of breath, using her accessory muscles to breathe. And you've seen this presentation before, and you're rapidly going through that differential in your mind. Does she have heart failure? Does she have a pulmonary embolism, perhaps cancer that they didn't tell you about? She could be having a heart attack. Could be obstructive lung disease, such as COPD. Could be an infection, and the list goes on. You get some vital signs, and she's mildly hypertensive, mildly tachycardic. She's not hypoxic, but hanging kind of in the mid-90s. Not febrile. And when you do your exam, there's no peripheral edema. There's mild pallor. And you listen to the heart, and sounds regular in rate and rhythm, except a little fast. No murmurs you can appreciate, no rubs or gallops. And you listen to the lungs, and you appreciate some crackles at the bases. Now, we think she has a heart issue based on what the husband said. She's got some crackles in her lungs, and there's no real big JVD or peripheral edema, but thinking more like heart failure right now. Get an EKG, and it's not exactly normal, but nothing on it really explains her overall presentation. So since I want to figure this out right away, I put the ultrasound on, and the first thing I like to look at are the lungs in the acutely dyspneic patient, and this is what we see. And what these are B-lines, so you can see straight vertical lines like flashlights going from the top pleura all the way to the bottom of the screen. There's definitely more than 3 to 5 in a lung field, so she has interstitial fluid, and I'm thinking this is cardiogenic pulmonary edema, especially when I see that it is bilateral. So I'm already thinking about the holy grail in emergency medicine, the disposition. This is definitely going to be a cardiology patient, right? So I want to confirm what I think I already know, and I look at the heart. But then, to my surprise, in this peristernal long view, the squeeze of the heart looks good. And so I got to fight this anchoring bias and try to figure out what's going on. Well, shoot, I was thinking about BiPAP, I was thinking about afterload reduction, and now I am not sure. Also, maybe this is non-cardiogenic pulmonary edema. This actually needs to be dispositioned to medicine. Perhaps she has mostly diastolic dysfunction, so I'm going to go to the IVC and just document that she's volume overloaded. And this is what we see. Nice long axis of the IVC, and it is very plethoric. It collapses easily. She actually looks like she's kind of volume depleted. So crud, I've sort of missed the boat, and I need to re-examine my differential. So I return to the heart, do a subxiphoid view, trying to look at contractility again. And again, it looks like good functioning heart. I don't really see a reduced ejection fraction. But what I do see this time is that there seems to be something very bright between the left atrium and the left ventricle. And that is a calcified mitral valve. For my last clip, I do an apical forward chamber. And man, oh man, what I see is a calcified stenotic mitral valve. It is bright, it is very hyperechoic, it is barely opening, it has very poor coaptation, which means that the tips of it are just not coming together. It has that hockey stick appearance where it's so calcified, it is so immobile, it just seems like it's fixed in space. Ding, 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 the light bulb goes off in my head. This patient has acute exacerbation of mitral stenosis. Now the picture totally fits. She's got pulmonary edema because fluid is backing up through the left atrium into the lungs. The cardiac function is good because it's a valvular issue, and the IVC is very collapsible because it's not a volume overload problem. So we get cardiology involved and also contact cardiothoracic surgery in case the patient needs an acute valve replacement. The translator finally arrives, and we find out that as a child, she had rheumatic fever, and this is the consequence. And here's the classic presentation of Walmart-induced cytokine storm, that exacerbated mitral stenosis in the patient that had a history of rheumatic fever.